Good afternoon, everyone. Thank you for signing in today. I'd like to introduce Dr. Sean Paul, one of InMode's key opinion leaders and oculoplastic surgeon out of Austin, Texas. I know Sean for a couple of years now, and he deserves all our respect because he was willing to try technology and push it as hard as he could to the limits in a very, very difficult area, the lower lids and the upper lids. So due to his expertise and hard work, he was finally able to figure out this protocol, which helps all of us tremendously because I don't think there's a lot of people out there who would try the things he has. So he has our respect, and he certainly has mine for finally attempting and finally figuring out how to get consistent results with the use of the AccuTite technology. So looking forward to listening to Sean today. And if there's any questions you might have, we'd love to take them. Now is the time and answer anything that you might have in mind. If there's something that you did not see or were not answered during this webinar, we're happy to address it afterwards on a one-to-one basis. But we'll try to accommodate everyone as possible. We know a lot of people are on right now. So just bear with us and we'll get started. Sean?
Great, thank you, Dr. Theodoro. I'm Dr. Paul. I'm going to go ahead and share my screen here with everyone. Dr. T, can you guys see my screen there?
Yep.
Great.
We can see your presentation. Perfect.
Excellent. So I'm going to do a brief overview of our treatment for radiofrequency around the eyelids. And just as a reminder to everyone, the full replay for the live lower lid case is on the InMode resources portion of the physician resources as well. So a lot of that will be based on that. And we'll go ahead and get started here. So I'm going to talk a little bit today about describing and sharing our innovative treatment for the lids. You can reach out to me through Instagram or through, you can message us today during the specific webinar, which is what the goal of today is. And really want to focus on that gap patient who wants aesthetic surgical-like results with less downtime around the eyes. And, you know, I was a user that started and really tried to help innovate this area and kind of make it easier to understand. And obviously with this influx of technology between radiofrequency and other treatments, and we really have to help one another as physicians to kind of guide our own destinies so we can have improved results. You know, a lot of the gap, the discussion on the gap patient really came from a paper written by Dr. Theodoro, Dr. Del Vecchio, and Dr. Chia. And they were able to use this radiofrequency technology around the arms as well as on the body, on the chest for cases like gynecomastia. In addition, additionally, we've had a lot of case studies come out on overuse of inappropriate treatments or treatments that are causing swelling or problems on the lids, such as tear trough filler. And so I think that in these pictures here, this patient had overfilled tear troughs and had to have it dissolved, have that more natural appearance. And we know that's a very sensitive area. So I think I've really pushed myself to figure out, you know, where does RF and specifically the bipolar technology we have with both the AccuTite and the Morpheus play a role as an alternative treatment or and hopefully a primary treatment for some of these patients. Particularly, I want to focus on the ophthalmic considerations, such as patients with dry eyes, non-surgical candidates, and patients who've had prior blepharoplasty as well. So why AccuTite? Well, AccuTite is a bipolar radiofrequency device that places one probe underneath the skin, underneath the muscle, or even into the fat in certain cases, and one and the other end of it on top of the skin. It causes the focal radiofrequency contraction without excisional surgery. And so a lot of what we're going to talk about today will be focused on just thinking, you know, we're basically creating something brand new, which is, you know, creating that surgical-like appearance, at least 30 to 50% improvement in those areas without traditional surgery. It's an FDA cleared for electrocoagulation and soft tissue and hemostasis. It's the smallest technology that we have, and I really relate this to the size of a filler cannula. I'm using an 18 gauge port to create an entry point. And you know, there's different areas that I've been trying the treatment on. And I really started to think of this as a minor tweak, so I didn't oversell this to patients. But as we've kind of gotten better on controlling temperatures, both externally and internally, I've really been able to remodel fat in areas I wanted to remodel fat, and also improve skin tightening in other areas. Lower eyelids, brows, submentum, other small areas, nasolabial folds, and then other body areas that we've explored. Here's sort of the whole spectrum of the InMode products, from BodyTite, which is kind of the original device that was used on larger body areas, down to the AccuTite. I use the AccuTite in conjunction with the Morpheus treatment quite often, particularly around the eyelids. And we'll talk a little bit more about the anatomy as well. But there's certain things that are really treated well with Morpheus on the eyelids, with the small focal contraction and the small tightening you can get, which can be analogous in some patients who need that additional tightening of the lower lids. Here it describes the depths. The Morpheus8 goes down in a fractional bipolar frequency pattern through the skin and through the muscle, and can really create focal contractions. So if you have those superficial changes on the lower lids and you want to tighten it, we even have a resurfacing tip as well that's 500 microns. That can really focus on the epidermis and dermis, and you can really get down to orbicularis muscle as well, and create that tightening that's needed in the areas on the lowers with that little skin laxity. And with the AccuTite, you can go slightly deeper as well, and the AccuTite can go into the deeper tissue. So we're going to really focus on the depths as well. And I think that that's really a critical part about the anatomy portion. So again, this is a safe procedure. It does heat up quickly, and so there's some certain guidelines you can see in our live video that really work well on how to be very safe in this area. Versus like an injectable filler or injectable fat, you really want to think of this as injectable heat and tightening. And so you can monitor and change those temperatures in safe ranges in the deeper areas underneath the dermis, as well as underneath and on top of the skin. Another nice part here is with the right amount of local anesthesia used, you don't need to aspirate. Again, handpiece specifications here, it's a coated tip, which provides safety. This is an important slide here to know that you're going to get 360-degree heating around the internal probe. And I think that's really important to note, that not only, and this is going to be really key on hand positioning and where you're going to place the internal probe on the lower lid, but you particularly get heating right above the internal probe, as well as 360 degrees around the internal probe. And that's really, really important. As for the external electrode, I use the Morpheus quite a bit with these patients, but on patients who you aren't using that on, there is a way to really focus on the external temperature as well. And so you can create those superficial skin and righted changes that you may want to focus on with certain patients. So I think that the key things we want to focus on is this is the future of aesthetics. Patients are going to want additional options. Additionally, we have so many providers doing injectable procedures, and we know the risk profile of injectable procedures is quite high. I mean, there's a lot of safety that really can't be addressed fully, and so I think that's important to address, that you want to work in these areas delicately, and this should be your armamentarium as a way to treat the lower lids. Now, brief disclaimer: when I first started to use the new technology, it was like when I was starting to do eye surgery. I started out in ophthalmology and went on to oculofacial plastics. But if you're not used to using a device in the room for a surgical procedure, it's a good time. You have to take the time to learn the technique. I know InMode offers training on site, which is really nice, at your own office, as well as a remote training. I do some of the trainings as well. It takes time and effort, and also a good patient selection. Important thing is that to mention to patients, because it's all about that preoperative evaluation, is to tell patients that they will get results. It does get better with time. You may not get the instant fill like you would with the filler, but you're not going to be dealing with the same complications that you can with some of the lower lid injections. So, begin in safe areas, do a lot of pre-counseling, and start to do a lot of cases. Now, this is a really nice view of the lower lid anatomy. I added this slide in here to kind of really go into detail. Particularly we'll focus on the lower lid. And so this is with the skin removed. The orbicularis muscle, when peeled away here, there's a pretarsal component that's higher up toward just below the inferior margin below the margin of the lower eyelid. The preseptal portion as well is below that. And you can see here there's an orbital septum and that's pretty deep. It's basically adherent down toward the bone, and that's a deeper tissue as well. And so that really kind of distinguishes the layers you want to be working in. Next, on the sagittal section here, and just in reference to the diagram we just saw, the skin is still here. The muscle, this would be the pretarsal portion, the preseptal portion, and here's that septum, again, deep and down and connected to the bone. Here's the fat as well. It's deep, and here is your inferior oblique muscle as well as your retractors. So through a traditional anterior approach surgery, where you're going through skin and pulling that away and the muscle and going that away, you have to go through that septum to get through the fat. And we're going to really describe the plane that we're working in here, which is preserving this tissue but pushing
mind
back.
if I interrupt you really quick, because this is a great cross section? Would you mind? I know you're going to show it again in cadaver sections and everything, but right off, just really quickly, where does your probe go here on the lower lid?
So our goal is to place local anesthesia in a submuscular fashion in between the muscle and the septum and elevate that tissue. The skin and the muscle are quite adherent, but you can create a nice plane in between. In patients who have larger fat bags or more steatoblepharon or more fat prolapse, they're going to have a larger bulge in this area here. And so it could be easier to penetrate this area. And in surgery, you're going to penetrate this area as well. What we're finding, and we've done a lot of these procedures, is if you can place a local anesthesia underneath the muscle, you can kind of open up this space. A critical component is we've all done skin pinches or we've done upper lid blepharoplasty where you're tightening skin and muscle, is to non-surgically tighten this muscle and skin. And remember that internal probe will be placed here, and so you're going to be able to create heat and gently contour this tissue and push everything back. And that's where we're seeing, and these are just principles of blepharoplasty surgery. You want to improve the tightening of the tissue. So what's really nice about the Morpheus is that with the 30% or more improvement in the tightening or the heating of the muscle and the skin, you can actually improve that tightening of the tissue. And then with the internal probe, you can actually heat the posterior aspect of the muscle and actually deliver heat posteriorly and basically shrink this tissue, just as if you were doing soft.
So Sean, just to interrupt again. So show us exactly where the probe would go. Is that below the green line, deep to the green line, beneath the green line and the muscle, orbicularis?
So here's your skin, here's your orbicularis. You're trying to place your probe here, trying not to penetrate into the deeper tissues where you're going to have the more critical structures, and this provides a safe plane.
And the green is your septum?
Correct.
Okay. So we're going, basically what you're saying, just for everyone to understand, you're going beneath the orbicularis and above the septum, correct?
Yeah. Submuscular is the way I describe it. And the reason and the muscle in this case is the orbicularis muscle. You'll see on some of our patient markings that you can see here, there's no need to go higher than 3 millimeters or 4 millimeters, which is that eyelid crease, which is where this tarsus sits. But it's really more important to go deeper on these tissues well. Now you have to remember too, if patients have exuberant lid laxity, they're not going to do well in these cases because they need a lid tightening procedure, and that's why we really have kind of been really specific about the patients that this works well on.
Okay, thank you, Sean.
Yeah, I wanted to also show exactly what Dr. Theodora was saying. This is a traditional anterior approach that a lot of us are not doing anymore. But again, just to see where everything where we're working. So this is your skin and your muscle here. And again, this is the septum opened up. You can see that fat sits fairly deep back there. And even in the most prolapsed patients, you can violate the septum to bring the fat forward, but it's rare that you see the fat going through the septum without surgical penetration of that tissue. And so, in these patients that need debulking, they need debulking, they need something surgical. But in patients that do have mild steatoblepharon or mild herniation, if you're heating in front of the septum, you can tighten this tissue. You can improve the tightness of the internal structures and push things back, as well as heat and tighten the anterior lamella. Anterior lamella means skin and orbicularis. Everything behind that is middle lamella, posterior lamella, and you I would not recommend without surgery going and exploring that area, because you're not going to be able to guide yourself deep in those tissues. And so it's important to make that distinction. And again, this is a surgical procedure, and I wanted to show this is like a canthoplasty or a lateral canthal tendon tightening procedure, but I wanted to demonstrate, why we're heating the orbicularis muscle on a younger patients. By heating the orbicularis muscle, they don't need a lateral canthal tendon tightening procedure or orbicularis suspension, because they have great lateral canthal tendon integrity. And so by heating the orbicularis, you get that mild tightening and improved structure. But this is an analogous thing that a lot of us have been used to from lower lid surgery. Now, with the septum pulled back, we wanted to point out some danger areas you could get into as well, and why you don't want to go deep behind the orbit, because the last thing you want to do is cause issues in those areas. And so if you're going too deep with your approach, you can really get into inferior oblique muscle. Although it's a resilient muscle, and it can resist some manipulation, which if you've done a transconjunctival fat transposition blepharoplasty, you can get some traction on that tissue, you can get diplopia. You really don't want to do that if you don't have to. And so we're not seeing the need to do that. Additionally, if you approach the brow, you want to be aware of the supratrochlear and supraorbital nerve. And if you haven't been listening really closely, these are really good slides to look at. This is really ophthalmology and oculoplastic specific, especially when it comes to anatomy. But again, these are reminders as well. If you don't know this anatomy well, or you haven't studied this area, it's a good time to take some time to do that. And finally here, just it shows you all the blood vessels in this area. And so luckily you have a lot of anastomosis and recirculation in that area as well. So any sort of heating is essentially just like applying light cautery to that area. And just for an analogous approach, so a posterior approach to the lid is cutting through conjunctiva and manually excising fat. What you see with this procedure, although it's an elegant procedure, is you're going to see some excessive chemosis in these patients. We're not seeing chemosis with our patients with AccuTite. Just wanted to show that comparison there. Finally, a couple other anatomies and good points that I use when it comes to in particularly applying local anesthesia to the patients. I have the patient open their eyes, and I'll palpate the supraorbital foramen, a supraorbital notch, and just one finger breath below that area, you'll find the infraorbital foramen. Sometimes you can palpate that. I typically do a 1 cc block of lidocaine in that area to provide a nerve block that provides patients to have comfort during the procedure in the office. And if you've done a lower blepharoplasty in the office with any sort of fat manipulation, you have to, I'm sure you know how uncomfortable that can be for your patients. Our patients do not complain of pain at all during this procedure. They don't complain of chemosis at all during these procedures. So that's why I really have taken a liking to this option for my patients who have that early change in the lower lid or genetic change underneath their lower lid. Additionally, just a reminder, again, from an anterior look or a coronal look on these, on the anatomy, on the muscular structures, this is a sphincter muscle. You're not going to necessarily get uniform tightening just with the AccuTite, but using Morpheus around the eyelids is really great. And Morpheus Prime should be coming out fairly soon. That provides actually an even more tighter, it provides an approach that's even more detailed in the tighter areas around the lid. And Dr. Theodora can let us know when that's coming out to the market. But I know that in our patients, we're really seeing even a delegatable treatment for patients who have really mild changes on the lower lip but want improvement. And if you're thinking about a canthoplasty or canthopexy or something tightening, Morpheus can provide that microscopic tightening in that area. And again, going deeper on these tissues as well, lateral canthal tendon, medial canthal tendon. I wanted to denote this diagram because it really focuses on a really big danger area you want to avoid, that sort of inframedial portion of the lower lid. This is where your tear trough sits. You can see with fillers why you can have a lot of problem in this area if it's not injected in the right plane. And so with AccuTite, you're performing injectable heat. You really don't want to overtreat these areas because you have a lacrimal system that you can get into trouble with. So I don't overemphasize that area. I'll still treat anteriorly and inferiorly, but not too medially in this area. But the key thing is you have to make sure they have great lateral canthal tendon stability. And again, anterior approach, septum's been pulled back and you're starting to see this fat come through. And so you're not trying to get directly into the fat, you're trying to heat in front of the fat, push the tissues back, and allow the tightening of the anterior lamella to basically retighten the lower lid and improve the contour. Just again, for variation anatomy here in an Asian lid as well, the crease is going to be lower on these patients. So you just want to think about how those anatomical differences are. In a westernized eye, the crease sits here. Here on an Asian eye, the crease sits lower. Here's your pre-tarsal orbicularis roll, or the jelly roll underneath the eye, and here's the pre-septal roll there. And again, just for the brow, don't forget about the temporal branch here. And the brow is an area I haven't studied intensely, but I know that's the next area we'll be looking at more in detail. And again, it's critical to know where you want to place the AccuTite for that region. Some good tests from a preoperative evaluation, the orbicularis oculi, you want to do a retraction test, see how much laxity there is in the lid. This kind of patient is a 100% surgical patient, so you wouldn't want to heat those tissues up because they have no stability of their lateral canthal tendon. So you're just going to create a bunch of swelling, and it's not going to be a good choice for you. Same thing here, pulling down the lid, see how loose the lid is. And from that pinch test on patients, you may potentially consider doing a anterior lamellar approach or skin removal. You can consider doing the Morpheus8 treatment by itself or in conjunction with AccuTite to tighten that tissue. So I think in terms of 3 basic layers of the lid: skin, muscle, and you should be underneath this muscle, essentially tightening this tissue as well as heating the tissue posteriorly and pushing everything back. So, I think selection criteria is something that hasn't been perfectly described yet, but our working selection criteria is, one, eyelids aren't for everyone. In general, a good age range would be 25 to 60, mild to moderate fat herniation. You don't want someone who has pre-existing lower lid laxity, and if they do, you want to do a lid tightening procedure. And really at this point, if they've had prior blepharoplasty, you're putting yourself at risk for lower lid retraction, so we just don't recommend that. I'm going to just play this, let me see here. I'm going to play this video here of the cadaver demonstration. Again, by approaching the lower eyelid and upper eyelid structure here. So the important landmarks to note on the lower eyelid are the lateral canthal tendon here, which is just adjacent or just below the corner here of the lid, or where the commissure comes together of the upper and lower lid. You can see here it's been released due to the dissection, and you want to identify if there's laxity in the lower eyelid. So that's the first anatomical landmark. The second one is the eyelid crease on the lower eyelid, typically about 2 to 3 millimeters under the lash line. The next is areas of steatoblepharon or fat prolapse, and there are 3 fat pads nasally, central, or medially, centrally, and laterally, and we'll identify those as we show the dissection further. And then finally, you also want to recognize where the fine lines here at the right is, which represent orbicularis muscle underneath. And you can see a beautiful dissection here as well. And this is the epidermis and dermis, and we're approaching here the beautiful orbicularis muscle, and that extends down to the lower face, which is again one of the muscles of facial expression. This is all innervated by the 7th cranial nerve and allows the eye to close comfortably. It's important to recognize that there are multiple layers in the eyelid that the AccuTite can safely treat by both increasing neocollagenesis as well as contouring. And so when we approach the lower eyelid, the skin and the muscle are the first 2 layers, and below the muscle here are deeper layers of the orbit, or approaching the orbit, including, Dave will identify the septum here, as well as the fat. And I have to give credit to my associate, Dr. David Gay, who works in my practice as well. He did an amazing job here. And you can kind of see through that there is where the fat is beginning to herniate through. And our goal with the AccuTite is to go submuscular. That's in a safe plane. That's where you'll inject your tumescent or local anesthesia. And your goal is to create a pool of heated, is to heat the pool of tissue there, the pool of tumescence there, and safely cause heating and tightening of the skin, the muscle, as well as heating the posterior tissues posteriorly without penetrating the deep orbit. So you're in a safe plane. So again, we'll enter back in through the same port here. And you'll feel a little pop here as you go through orbicularis muscle, which is everything just going underneath the skin. Ultrasound gel, sterile ultrasound. And all these videos are online through our resources as well if you want to review them. The back, you want to drop to your wrist and make sure you're not too superficial, because if you're only going under the skin, you're going to create some excessive postoperative swelling. You want to make sure you're submuscular, and it's nice because you can see that you're not seeing the tip clearly, and also you're not so deep in orbit that you're feeling a full resistance. And you want to begin initially to do a withdrawal technique, and since this area is small, you can slowly fan, and I began again at the initial mark, which was 2-3 millimeters below the margin at the eyelid crease, and we treat downward toward our treatment area here. So we'll demonstrate the withdrawal technique. You can hear the gentle contraction. There it goes. And we're going to reflect the skin back.
Sean, what is that sound, that triple beat? Would you mind telling us a little bit?
Yeah, so the triple beat essentially means you've reached internal temperature. And I would say when you're beginning, you should be starting between 60 and 65 internally. Dermal fat here as well, and there is some submuscular fat, which is nice for demonstration purposes. But our preferred patients or younger patients are going to have this anatomy, which is more favorable for the AccuTite. So we like to have patients under the age of 60, and as opposed to older patients who've lost a lot of that fat in the face. And our goals are not to melt or dissolve fat at all, but to contour and provide gentle skin tightening. So when you've reached the triple beat, you can know you've reached the temperature in that area. From this angle here, what it looks like.
So what are you demonstrating? Could you walk us through this again right now, Sean?
So this is basically subdermal and also some submuscular fat in this area here. You know, it's all reflected away, but we're demonstrating here that you can get that triple beeping and actually heating and gentle contouring, and how precise it is. It's really hard to overtreat these areas unless you're going back and retreating multiple times. You don't need to do that. But what you're actually doing is you're creating this fanning pattern of heating underneath the tissue to tighten the anterior lamella, which includes the skin and the muscle, and then also gently contouring the fat posteriorly, and you're not in the deep orbit, which again, the key point of AccuTite is not to go too deep and disturb the ophthalmic structure. Go retreat, there is a risk for excessive swelling in these areas, so we choose not to do that. So, and here's a quick demonstration here, and then we'll get to some more Q&A as well. And here's a live patient that we did, and this will be on the video online. This is again repeated demonstration. Going back and forth very quickly to the tissue. You just want to gently heat and gently provide the ability for the radio frequency to work. As you can see, I did reach temperature on the first pass. You don't need to reach the first pass, it may take multiple passes. So the triple beat basically tells you you've reached a temperature. I know in some cases you may want to go back and heat in the lower lids. You don't want to do that. That's going to lead to excessive swelling, and it's just not necessary.
So what's more important here, Sean, the internal temperature or the external, in your opinion?
So in this patient, she had mild prolapse fat. You can see this full video online, and our goal was to contour and push back that fat by heating and tightening the anterior lamella with AccuTite and the Morpheus, as well as, and that was with an external temperature approach, and then the internal temperature approach is really to push back the deeper tissues. And so we use both on her. If you have a young patient who has really smooth skin and just has puffy eyes, then you focus on the internal temperature. because they already had that canthal tendon that's stable.
Yeah, is this video playing, Natalie, or is it too heavy?
That was it. It just finished.
Oh, just finished. Okay.
Yeah.
So, all right, walk us through the case study. Excellent, Sean.
So
Thank you.
just a few case studies here. This is a patient, lower eyelid specific, basically had the combination treatment of AccuTite lower lids, bipolar needling underneath the lids. This is a patient, I know they're smiling a little bit, but we did combination treatment here with heating the lower lids, tightening them, and then also place some filler as well for more cheek volume. And here's some angles as well so you can see what those lower lids look like. Here's an older patient that we did the combinations. This is a good example of fat herniation plus the wrinkles underneath the skin, and you get the pushing back of the herniated fat, plus you get the tightening of the anterior lamella, which was definitely added in more tightened appearance on the lower lid. And this is each angle here as well.
Sean, how much lidocaine are you putting into these patients on average for lower lids?
So when I first started, I was over tumescing the tissue. I was putting in over 5 cc's under each eyelid. As we know, the lymphatics around the eyelids are very sensitive, and so if you have excessive swelling, I mean, you can have excessive swelling if you do that. So now I'm using about 2 to 3 cc's of lidocaine, typically about 2.5 to 3 cc's underneath each muscle on both sides. And then we're doing topical numbing as well if they're doing the Morpheus if they need that. And then we're also doing about a 0.5 cc to 1 cc block of local, so total about 3 to 3.5 cc.
Is that per side or total? Is that per side or
per
total?
side? That's per side. And then this is a younger patient, excellent tendon stability on each side, and just had the herniated fat as well on each side. And our goal here was really to improve this. She did not want filler at all. And because we're able to, with the AccuTite, really heat that tissue, and she just liked the way the Morpheus felt around her lids too. We did that as well. And on this side, I would say it's about, about 50% improvement, and she has a little bit of hollowing left, but again, really, really nice improvement. She's even looking up a little in this picture, which would herniate the fat a bit more, but at a straight view, she's very happy with her results. This is a patient who did not want surgery, was really against any sort of surgery at all. And you can see sort of this fullness in the nasal, central, and lateral fat pad, as well as some of the wrinkling here. And that's what I'm looking for in the Morpheus patients. And just kind of had deflation of that tissue. And this is when we really found that it was repeatable treatment. He has that early festooning. Now, festoons can be treated with AccuTite and Morpheus as well. Just prepare your patients that if they have severe festoons, they're not going to see much improvement, but the mild to moderate festoons, you can try it. A lot of those patients still need some sort of surgical intervention, but for mild to moderate cases, you can try this as well. Again, here, just underneath the eyelids as well, mild changes, as well as some of the neck changes here with the face down on the neck. These are just more jawline cases, but here's another patient here underneath the lids, and she also had jawline as well with the face tight as well. So post-operatively, compression has been a very, very nice addition to our post-operative care for these patients. We use a product called the Lid Lift Goggle. I'm happy to, if you can message me, I can get you information on that. We've added that. It basically looks like a ski goggle. But just as if you do, just like when you do a face tight procedure, or you do a facelift procedure, or you do a body tightening procedure, the compression garment has, number one, helped improve the swelling underneath the lids after the procedure tremendously. Instead of having extended swelling just because they didn't know what else to do in that area, they're really seeing a quicker improvement. I think ice compression is okay to use. I know we don't always love to use ice or cool compresses when we're doing radio frequency because of the heat, but in our experience, that swelling has really been improved quite a bit by both of these. And these are also just routine things you can do for dark circles or for swelling underneath the lids as well.
How long do you leave that mask on?
So the mask, it looks like exactly like a ski goggle. We send them home with it, so they're wearing that goggle on the way home, and then We just have them wearing at night, wear them at night for a week to 2 weeks, and it's just improved the swelling tremendously.
Do you use any antibiotics post-op or anything else you do?
You know, we're not doing a cutting procedure, but out of routine, I do use either Keflex or clindamycin for 3 days, just because you're doing a lot of different things on their face, and just as kind of a precaution. I don't think that's a necessary thing you have to do. When I first started doing these treatments, I just like with the lower bleph, I was calling in pain medication. I'm not having to do that at all. Patients are fine with Tylenol afterwards if they need it. Pain's not something that I'm hearing a lot of complaints of at all. I just feel like that's a rare thing to happen. Essentially that's it.
Hey, Sean, would you mind going back to a couple of your cases?
Yeah,
The ones that you've used Morpheus with?
sure.
Okay, and walk us through the settings. And first of all, why use Morpheus? And what settings are you putting in at? What kind of energy are you doing?
Yeah, so in this
Like
case
this old
here,
patient, for example.
yeah, so this patient here has the fine lines underneath the eyes. I really wanted, again, the way I think about it is if they have fat, which she clearly does here in both lower lids, I want to use the AccuTite to heat the tissue, and that's full tissue, but from skin, muscle, and down toward this, basically to the deeper tissues as well. So you're getting that uniform heating across. So that's really addressing the fatty areas. It's also going to obviously heat some of this tissue where the orbicularis is. What I like about adding Morpheus to these cases is you really get into the little nooks and crannies, and you get even a more precise treatment on the anterior portion of the treatment. You know, the skin and orbicularis muscle combined typically is about it can be as thick as 2 millimeters, but as thin as 0.7 millimeters when you combine it all together. So the older patients are going to be a little bit thinner, and so it's really hard to be precise without getting needles into each of those tissues. So I'm picturing micro contractions at each of those little needles and tightening the skin. And if they have good lateral tendon a good tightened tendon, they're going to just get a nice little snug of that tissue, and it's going to help improve the contour of the lower lid.
Now,
And then
Sean, just for the audience, now the tip you're using for the lids is different than what's out there available currently, right?
these cases were done before the Morpheus Prime. This was done with the traditional Morpheus. So
So yeah, I know we're doing research on a smaller Morpheus tip that's gonna fill in perfectly for that area, but use this with regular Morpheus, right? The big,
correct. So
larger one.
regular Morpheus, this is well before I had that to kind of start doing our work on that area, and it works nicely. And I think patients are really happy that they had this done in the office. And 2 to 3 months later, you could really see. And I saw this lady at 2 weeks, at 6 weeks, and then at 3 months, and she just had that gradual improvement, and she just loved not having the restrictions after surgery like you traditionally would, because you're not opening up tissue and cauterizing and sutures.
How would you modify the energy according to the lids for the Morpheus?
Good question. I think, it depends on if they already have the local anesthetic in. I mean, it's really easy to treat the lid with a higher degree of heat. So you can go to, up to 25 or higher, but I think 25 is a good number. And depth wise, I would say 1 and 2 millimeters for sure, and 3 if they have some more fullness that you want to contour on. And if they have a festoon, you can also even go down to 3, and you can try 4 if they have a really full festoon, but then you start thinking about surgery in those areas.
Okay, great, Sean. Just because you did one treatment of Morpheus during the operation, would that preclude you from doing follow-up treatments? And if so, how spaced apart would those be?
I do mine 4 weeks apart. She also had 1 additional treatment of Morpheus in between this as well. She wanted to work on other places. So, although I focus my research on eyelids, we treat fully, forehead, nose, right as around the face, and chin and neck. So she liked the treatment. She liked the way it made her skin look, and just liked the way it just sort of tightened everything, and to give her a natural appearance where her friends didn't make her feel like she had some major surgery, and she just looked really
And
natural.
the follow-up treatment, Sean, you would use just BTL cream with the Morpheus, or would you
Correct.
still have to use local anesthesia?
Correct. We do not use local anesthesia at the follow-up treatments.
So just BTL cream,
Correct.
sort of betacaine, tetracaine, lidocaine.
Yeah, or we do a 70-30 tetra, but but typically BTL is sufficient. We occasionally use nitrous oxide or Pronox as well, which is helpful because patients who have anxiety, we don't traditionally call it an anxiolytic. It's certainly not a pleasant procedure where they're not going to feel anything, but the patients who have seen the results, they're going to really appreciate that. If they're feeling it, they know the tightening they're going to get.
Okay, great. We have any questions more, Natalie, by any chance? I think not.
I think we're all caught up.
Okay, great. So if we have any questions, you can definitely ask Dr. Sean Paul directly if you'd like. What's your Instagram handle, Sean?
Yeah, just Dr. Sean Paul at Instagram. It's the easiest thing to
Probably
do.
the easiest way. And if you have cases that you like for him to review with you, that'd be great. And Sean, I really appreciate you taking the time today to walk us through a very, very difficult initial learning curve, but it seems that you made it very quite simple for people to be able to reproduce it. The last question I have for you, Sean, is I'm a newbie and first lid case I'm going to do, who would I pick? What would be the ideal candidate for it?
I think you want a patient who has mild sciatoblepharon or mild fat herniation and just a tiny bit of changes on their skin. And so you can use both the AccuTite and Morpheus. You can get used to using both. The beauty of just doing a lid-only procedure versus doing face and other areas is you can do this procedure in about 45 minutes in your office, which is really nice. So I would start by getting the patient comfortable in the office. I would put local anesthesia in, prep their face, and essentially then do the AccuTite as we just demonstrated. On the live webinar that's online, we'll show you exactly how to do the lids in that area as well. And then, basically the Morpheus takes a little longer than the AccuTite. The AccuTite takes about 10 minutes, and the Morpheus takes about another 10 to 15 minutes. And then, it becomes something you can have as a procedure during your office day. And then you certainly, because if this is your first patient, you want to, number one, set expectations very low because you don't know how well their tissues will respond, how they're going to swell. You're going to want them to have a compression device on their lid afterwards. And always, always, always have them scheduled for follow-up Morpheus treatments for at least 2 additional treatments because you want to follow up and keep tabs on them. These are really happy patients that get that mild to moderate improvement because a lot of patients just don't want surgery. And that's what I was shocked about when I added the AccuTite and FaceTite and Morpheus to my practice is how many patients will choose an option that's middle of the road, and always leave the option for surgery in the future because 30 to 50% for them may be good, or if the expectations are set appropriately. But if you're going to tell them you're going to replace surgery, you're going to set yourself up for failure. So you want to make sure you leave that open as a second option.
Question, last 2 questions. When to use a resurfacing tip in these lower lids versus a standard tip down to 2 millimeters or 3 millimeters? And when do you tell patients they can see results?
So resurfacing tip, we've kind of added to most of our cases because we're getting even more of that superficial. And I think the terminology that it's called is basically an ablative RF. That's correct, is what we're calling it. So basically it's an uncoated. So you get, they get that instant tightening and redness and that feeling, and they love it. So we've added that as well to the treatment protocol. And then results, I think it depends on how severe their bags are or how full their lids are. I think if you have really full lids and you're looking for a 50% result, I would say 8 to 10 weeks are going to see their final result. But patients are seeing result. I mean, obviously, when we first started, okay, you see results in the first few days, but we know that's just swelling. But when that swelling goes away, neocollagenesis happens over 9 to 10 months. So you have to again talk about that component that you're rebuilding skin, you're heating the tissue, and that's going to continue to tighten. But patients are impatient, so you have to be very honest with them and say, you're really going to see results at about 8 to 10 weeks, sometimes even 6 weeks, as long as you're doing compression on the lids. That compression is critical, a critical part of it. But I think it's a learning curve, just like anything else when you're doing your consultations, and you want to have patients who know that you care about them, that you want to give them realistic results, but also that you're willing to work with them and take care of them. And you're going to have patients who maybe feel like they need surgery again in the future, and that's okay. But you want them to stick with you if they're ready for that. But a lot of patients just don't want the downtime, or they don't want the anesthesia associated with surgery. So that's why I like it, because it's another adjunct.
Sean, last question, downtime? What do you tell your patients? If they want to do this on a Friday, can they go back to work on Monday or Tuesday?
It depends on
use your mask.
if they the biggest thing is social downtime. I would say from a outing downtime, they can pretty much do whatever they want to do within the next few days. I don't really restrict them from, I tell them to avoid sleeping on their face and avoid doing heavy lifting and straining or working out excessively, but they can go to dinner, they can do whatever they'd like to do. I think the social downtime varies from patient to patient, just like anything else.
Question from the audience, Shant. Do you use multiple entry points for the lower eyelid?
So initially I started to. I was doing an entry point 1.5 centimeters lateral to the lateral fat pad, and then I was also doing one mid-face, but I'm really able to approach it all from, and it's a really safe plane to go from here to here. If you're going to go from here to here, there's a risk if the patient jumps or something, you can get into a bad position. So, oh yeah, and one other point I did want to make too that wasn't demonstrated in that, but it is online, is that pushing the retropulse in the eye or pushing the eye back a little bit brings those tissues up forward for you as well to heal a little bit easier, so you're not having to, just so you don't risk just going underneath the skin only. And you're going to feel that muscle and pop as well, the pop to the muscle, and that's a critical part of this procedure that I figured out. But Dr. Ravati really helped me figure that part of the procedure out. I didn't understand that, but it's really helped create a uniform tightening.
And you told us about how many times already, and you also told us about the energy settings. All right. Sean, thank you so much.
Sure
we certainly appreciate you taking the time today. And again, if you guys have something specific you want to ask Dr. Paul, feel free to contact him on Instagram. But I'm sure that 6 months from now, things will be even better, and you'll be able to push the indications even more. So definitely have a lot of faith in you, Sean. And thank you for taking the time to figure this out. Appreciate
You're welcome. And if anybody needs to get a hold of me, again, Dr. Sean Paul on Instagram, or you can actually message the marketing team back at InMode and they can get you to me.
Okay, great, Sean. Thank you.
All right, take care.